Malnutrition can be defined as not eating a diet with enough nutrients. A patient may have malnutrition for many reasons: lack of available food, lack of dietary knowledge, illness in which one of the symptoms is lack of appetite, or a swallowing disorder are some of the reasons a patient may suffer from malnutrition. CDI has had its struggles through the years with the assignment of the malnutrition as a diagnosis. One of the struggles is that the physicians are not comfortable documenting malnutrition. Some physicians think that a diagnosis of malnutrition looks bad for their physician profile, and some physicians do not feel comfortable documenting a level of severity such as mild, moderate, or severe. Another problem CDI programs face are the payers have been known to audit hospitals who code severe levels of malnutrition more than their counterparts. Coded diagnoses of kwashiorkor and/or nutritional marasmus have also been targeted by the auditors. Payers have recouped millions of dollars when they reviewed hospital records with malnutrition coded and found the clinical indication for the disease was not documented or supported in the medical record. Recently, hospitals have teamed up with their nutritionists to develop criteria for the 3 levels of malnutrition. The criteria can be sent to the physicians who are uncomfortable documenting a level of malnutrition as a reference. Some hospitals have worked with dietitians to document the level of malnutrition the patient has in their note. The CDI will then send a query to the physician for agreement of the dietitian diagnosis of malnutrition. 2 popular diagnosis criteria are the Aspen criteria and the Z-score. The Aspen criteria is most often used in adults, and the Z-score criteria is often used for pediatrics. The World Health Organization has a great reference in regards to severe malnutrition that is an excellent reference for CDI coders. There are many primary diseases that can lead to malnutrition. Cancer patients that are at high risk for malnutrition. If the cancer is in the head or neck region or the gastrointestinal region, it is harder for the patient to swallow and digest food. Side effects of chemotherapy and radiation can decrease the patient's appetite. Patients with chronic kidney disease on dialysis are also susceptible to malnutrition. Nutritional loss during dialysis, deficient nutrition intake, and hormonal and gastrointestinal disorders are a few of the causes. Patients with liver disease, such as cirrhosis, are known to have metabolic disorders which can lead to malnutrition. There are cases of malnutrition in otherwise healthy people which are due to social situations such as poverty, homelessness, or neglect. Signs and symptoms of patients with malnutrition include adipose tissue wasting, muscle atrophy, cachexia, dysphagia, and fatigue and weakness. Adipose tissue wasting is the wasting away of muscle and fat. Muscle atrophy is the loss of muscle tissue. Cachexia is defined as a condition of weight loss. Muscle atrophy, fatigue, and weakness. Dysphagia is a swallowing disorder. Emaciation is a term used for patients who are malnourished. It means a person is abnormally thin. Patients with malnutrition often have a decreased hand grip, nausea and vomiting, and weight loss with low BMIs. A clinician will request a dietitian evaluation based on physical appearance and risk factors for malnutrition. This is considered a diagnostic test. Clinicians will order lab tests such as transferrin, total iron binding capacity, prealbumin, hemoglobin and hematocrit, and glucose levels for patients with suspected malnutrition. An abnormal decrease in these labs can be a sign of malnutrition. IV fluids are often given to a patient with malnutrition to ensure adequate hydration. High-calorie nutritional, dense oral drinks are often prescribed to patients with malnutrition. Vitamin supplements are prescribed when a patient has a specific vitamin deficiency. Patients are encouraged to make dietary changes if the malnutrition is due to lack of knowledge of healthy nutrition. Enteral and parenteral nutrition are often given to patients with severe malnutrition or patients who have swallowing disorders. Parenteral malnutrition, also called TPN, is the feeding of a person through an IV. Enteral nutrition is the delivery of nutrition via tube through the gastrointestinal tract. The tube is also called a PEG tube. Since the inception of ICD-10, the procedure code for TPN increases the severity of illness profile in some DRGs. Common clinical indicators of malnutrition include adipose tissue wasting, altered gastrointestinal function, anemia, atrophy of the muscles, a decrease in BMI, breastfeeding difficulty, cachexia, cancer, recent or current chemotherapy, chronic kidney disease, chewing difficulty, diarrhea, dry or peeling skin, emaciation, fluid accumulation, gastrointestinal disorders, diminished hand grip, patients on hemodialysis or peritoneal dialysis, inadequate food intake, hyperglycemia, hypoglycemia, liver disease, loss of subcutaneous fat, muscle loss, nausea and vomiting, weakness and fatigue, and weight loss. Common diagnostic tests for malnutrition include prealbumin, BUN, BMI test, creatinine levels, hemoglobin, hematocrit, glucose, measurements of weight for length, pediatrics, measurements length, height, pediatrics, measurement of weight loss, measurement of food intake, total iron binding capacity test, and a transferrin test. Common therapeutic treatments of malnutrition include IV fluids, TPN nutrition, which is feeding through an IV, vitamin therapy. Possible query options for malnutrition include minor protein calorie malnutrition, moderate protein calorie malnutrition, and severe protein calorie malnutrition.